is actually the last seminar of the spring, believe it or not. So there'll be, unless there are some special guests, there'll be no seminars. At this point, there is nothing planned for the summer. So this is basically the last opportunity to eat sushi. I hope you enjoy. Anyway, I'm happy to have Dr. Sanjiv Naryan. So for Sanjiv, it's homecoming because he was a fellow here, both
cardiology and EP.
Cardiology and EP. About 6 years it's been.
5.
That's as long as I've been here. So he was here for 5 years and is doing his fellowship in cardiology and EP. Before that, he received his MD from the University of Birmingham in England. And also, you'll be interested to know, received a master's degree in software engineering. That was a surprise to me.
Crazy.
So,
anything I can do to extend the length of training.
We're all still being trained. So anyway, so he's now at the University of California in San Diego, where he's co-director of the EP program there at the University of San Diego, and also involved in research. Sanjiv has done some beautiful work on T-wave alternans, and also, of course, on atrial fibrillation, and he will tell us today on the mechanism of atrial fibrillation in humans from mapping studies of both activation and repolarization. Thanks for coming.
Thank you very much, Yuri. Thank you very much, everybody. It's really terrific to be here among old friends, some not so old, and I make no apologies. This is going to be primarily a clinical discussion, but I hope there's enough translation to keep the rest of you awake, and if not, there is plenty of sushi. Feel free to stop me at any time and ask me any questions, with the exception of Mitch and Jane. I refuse. I'm not kidding. So basically, I have a few disclosures. We have fellowship support at UCSD from some or all of these companies, and I've also spoken with them on occasion. So basically, as you all know, atrial fibrillation is now an enormous public health problem, and it's something we in EP spend a lot of time seeing, treating, ablating, and managing. And it's a bit of a surprise in 2010, because really, if you go back, when the first descriptions of AFib ablation were reported in 97, Circulation 98, New England Journal, many of us felt that we'd really have AFib licked by, within 5 to 10 years. But here we are, clearly we haven't. To the point where the words of the following politicians spring to mind. On coming into office, this famous man said, "Our critics predict that we will fail. We will exceed their expectations." Okay, so atrial fibrillation is an enormous public health problem and the most common arrhythmia in the United States. And in a nutshell, if you look at the US population prevalence, if you will, in tens of thousands on the vertical, and the age in bands of 5 years, the overall population is in the red lines. And you can see that the majority of the population is in the middle, quote, ages between 30 and 60, and then the population tails off. However, the prevalence of atrial fibrillation shows a quite opposite and markedly different prevalence trend. It is prevalent particularly in the ages of 60, 70, and beyond, as you can see, and this prevalence curve is in thousands, so 100, 200, 300,000 for these age bands, giving an estimate that was taken for many years as being correct of over 2.2 million people. That's the good news, because the bad news, I'm sure many of you are aware, are that not only is that increasing because of the graying of America, but more recent epidemiological studies suggest that those are underestimate figures. So from the paper from Miyazaki, Circulation 2006, they used Olmsted County as their experimental crucible and measured the prevalence and incidence trends over the past 20 years, and showed that in fact, and extrapolated to the US with all the limitations thereof, and found that the current prevalence is probably more like 5 million, and that projections based on incidence acceleration over the past 20 years suggested that by 2050 we'll be up to 12 to 16 million, which are basically 2 to 5 times current estimates. And if you read the papers, some of the acceleration can be thought was due to hypertension and other comorbid conditions, but a lot of it was due to this trend. Not actually this one, but actually this one. And I'm sure you're aware that there's a direct relationship between obesity and atrial fibrillation, which is a little difficult to understand mechanistically, In this particular paper, which is observational only, it's been suggested it's left atrial size. Nevertheless, in the Miyazaki study, BMI was the single most powerful predictor of atrial fibrillation. So for those of you who don't know, AFib is a clinical diagnosis. This ECG is not completely normal. I know that, Mitch, but it's hard to find one of my files read by Ben Barzilai. So this is sinus rhythm. You can see in all 12 leads that we have quite a regular pattern. Obviously, you have PQRS, and the consistent regular P waves with an axis that's basically inferior, suggesting a high atrial source, are consistent with atrial fibrillation. And again, for those of you who haven't seen this before, atrial fibrillation is quite different. If you look at this, not only do you lose this lack of regular QRS complexes here, it's very irregular, but the reason is because the regular P waves that signify laminar or regular activation on a beat-to-beat interval with a pause in between are gone, and they're replaced by this very irregular and essentially continuous activation of AFib. So what does the heart look like in AFib? This is from the inside of a saline-filled porcine heart. Video image, this is part of the Medtronic Virtual Heart project. So you don't have the contraction you would expect. Instead, the atria is quivering because the activation electrically is so rapid. So two things you'd imagine. A, you don't have much contraction. And B, you can clearly see the structural elements, trabeculae, pectinal ridges, depending on whether you're true sinus venosus derived atrium, which really are a setup for the major clinical problem in AFib, which is this, which is that untreated, in addition to other things we'll talk about, atrial fibrillation patients have the propensity for blood to become static, sit in those crevices and recesses, and clot, and that can be made one of the major clinical sequelae. And in fact, stroke, thromboembolic events after that are probably the most feared complication of AFib. And the incidence is roughly 5% per year, varying with risk factors. And I can go into this later, but basically the risk factors are some of those listed above. The second major clinical sequel that's important are that because you have irregular and rapid QRS complexes or ventricular activations, you can present with a heart failure syndrome. Patients with atrial fibrillation can appear to be more fatigued because the irregular QRS intervals give them irregular ventricular filling, or also because the rapid ventricular rates can give a tachycardia-related cardiomyopathy. There are actually other reasons too, loss of atrial kick and some other speculative ones. In the atrium, the presence of AFib tends to facilitate future AFib. One of the reasons we try to stop it early, but if it's unchecked, then this itself can cause atrial dilatation, which makes the whole process worse and increases the rate of stroke indirectly and so on. And all of these give rise to symptoms, in addition to those I've described, of non-specific palpitations, feeling irregular heartbeats, lethargy, fatigue, and so on. So I'm doing this quickly to get into the meat of the talk, but the therapy, therefore, is really in three prongs. One of the first things we think about is not how to stop the AFib, but what are we going to do to manage this patient's risk for thromboembolic events? And there's a strategy we go through based on risk factors, and that's probably the mainstay of therapy for every AFib patient. Of course, when you think about ways to thin the blood, giving either true anticoagulants or antiplatelet agents, there's a risk of bleeding, and of course this strategy accepts AFib. The next potential strategy is that for controlling the ventricular rate, so it's not so rapid, that may eliminate some of these symptoms, but again, this accepts atrial fibrillation, which leads us on to the third, the intuitively obvious strategy of maintaining sinus rhythm. But of course, the problem with this is that the drugs you may think of, the non-clinicians, I'm sure you've heard of things like amiodarone or flecainide or sotalol, drugs in Vaughan-Williams classes 1 and 3 in particular, but their efficacy is far from optimal. They're quoted as being up to 70% effective. I would really argue with that number because all those studies have used very, very suboptimal ways of monitoring atrial fibrillation, such as monthly ECGs. They're probably far less effective than that. And that's where ablation comes in. And the reason I think this is a very important point in the field of AFib evolution is that we now have potential tools, ablation, whereby potentially we can identify a mechanism for AFib, ablate there, and slow or terminate it. That will be the holy grail. The problem is, what is the mechanistic target for AFib? So this is a job I wouldn't recommend. Maybe marginally better than medicine intern, not sure. But basically, what is the mechanistic target for AFib? Because unless that's defined, then performing ablation is essentially guesswork. If we think about the paradigm for ablation as developed as part of the Cox maze or going back in time, Wolf, Parkinson, White, identify a mechanism for the arrhythmia, target it spatially, and apply energy to that location. So can we use that paradigm? So so this is the right and left atria, this is the sinus node and sinus rhythm, of course. You'd have activations roughly, let's say once a second would be 60 beats a minute. The activation spread across both atria in some form. It has been shown since 97-98 that in fact short-lived episodes of AFib that stop and start on their own can be initiated by premature atrial beats that arise typically, not always, but typically near the pulmonary veins. And these can give rise to wavelets. Again, it's not clear whether this is repeated beating from these areas or short-lived reentrant waves, but nevertheless, at this point, the atrial fibrillation is often non-sustained. Over time, a series of processes ensue which allow the AFib to persist. These include a variety of things. One of them are atrial remodeling, which I'm going to show here, which includes a variety of factors that really Rick and others at WashU did some seminal work to elucidate by looking at the effects on repolarization of atrial cells and conduction velocity, and showing that over time the atrial remodeling process, no matter what that is, ends up shortening refractory periods so that the atrium can beat quicker, making conduction velocity slower so that reentrant waves can become smaller because the time taken for a wave to start at a point and re-enter and still reactivate it can be a smaller spatial space if the conduction velocity is slower. And these are some of the core elements of atrial remodeling. Another interesting fact is that many rhythms which are completely organized, including some atrial tachycardias and atrial flutter, can actually also degenerate, quote, to atrial fibrillation. So this is one potential framework for AFib, ending over here with long-standing persistent atrial fibrillation, where waves exist which, according to one hypothesis, meander, collide, extinguish within the atrium and shouldn't have any fixed orientation. And that's really one of the bases behind the Cox maze that we'll talk about a little. And obviously Rick's here, so I have to be careful what I say. One of the things that I find difficult to understand is that in long-standing persistent, you'd expect that if you had reentrant waves, that you would have a homogenization of rate and organization within the atrium. We do actually see gradients of rate, typically the left atrium faster than the right. I've tried to show this here by smaller waves here, just indicating in this case, for example, right may be quicker than left, but there is a non-uniformity. So it has been suggested, in fact, that for that reason there might actually be focal drivers. In this case, I've shown a very small reentrant circuit, or it could be a focal beam. So how would we treat these? One is drugs, which we've discussed. Another would be to perform ablation of the atrial flutter, and for rhythms like atrial flutter or atrial tachycardia, this is very effective, 90% success, because we know the mechanism. Now, when you look at paroxysmal atrial fibrillation, where you have triggers around the pulmonary veins, you'd expect that if that were truly the only mechanism, that intervention would be successful. It actually is successful, but one procedure success is reported really in 60 to 80%. When you get over to this side, where you have far more complex AFib, then the strategies involve ablating around the pulmonary veins, drawing lines potentially along in the right atrium, not so commonly done, drawing lines to the mitral tricuspid annulus. And although we do this repeatedly, and a lot of patients have clinical benefit, if you really look at the success rates for one procedure, these are probably where the numbers are, 50 to 70%, one procedure success. It doesn't really
I have a question. Before you continue, just how do you define success? Do you take into account recurrences? How long do you follow up patients?
So in a nutshell,
what do you mean by success?
That's a great question. What's the success of ablation? So this is a point of controversy. If we were really dealing with a defined mechanism, you can talk about complete elimination. Then the question is, how do you detect recurrences? And the more we look, the more recurrences we see. So if you look over time, from the early 2000 studies to now, you can see the more closely you look, the success rate tends to drop. Initially it was felt atrial ablation was 90% successful at 1 year. Then when we started to do Holter monitors, event monitors, and now even we put loops into our patients, put reveals in UCSD, the success rates are dropping. because of that, actually some prominent papers, such as Maradi's recent paper from Ablation Frontiers, didn't even use elimination. They spoke about a 90% reduction in burden. So what you're saying is an excellent question, and it highlights the fact that I don't think, and of course most people would agree, that we have a good handle on what the mechanisms of AFib are. And even, I think, even the paroxysmal case where pulmonary vein isolation has this success rate, you know, you could argue that other mechanisms may be involved. And I think it's just a very interesting point to be looking at mechanisms.
So the numbers that you're giving are reported quotes from the literature. They don't have a uniform definition of success, right? Some of them over a longer period of time, and some of them over
the AHA
1 year, yeah. So the success rate would be 1 year. Well, these numbers are from a series of studies that looked essentially between 6 and 12 months of follow-up.
So that's okay.
That's
Yeah, that's all. I just wanted to.
Oh, you wanted the short answer. You never get that.
That is
sorry.
the ablation answer.
I'm sorry, that I should have guessed. Okay, so.
But thank you for explaining.
Okay, so this is the same thing put more differently. This is the Worldwide AF Investigators study from 2005. The more recent one that came out in 2009. It's basically the same results. Success minus drug, you're hovering at 60%. So why is it only that number? You could think about two potential hypotheses. One is we put the lesion down and it recovers because it's very difficult to get complete burns through the atrium, especially if you're putting down 30 or even 100 burns. That's one possibility. Another possibility is that there are additional targets beyond where we think we're going. So let's think about both of those. This will be a typical map. This is an older figure because there's a posterior line, but basically this is looking at the back of the atrium. You've got sorry, this is the roof, and this is the back. The left veins, the right veins, this is the front of the patient, this would be right and left. And as you can see, each of these dots is placed manually by the operator when their catheter inserted through the vein is at that position. You can see straight from this there's a potential gap. That may or may not be true, but of course it could also be true that not all of these lesions are completely effective. So it's possible that there are gaps. There is of course another possible, and so that is one area where surgeons could have an opinion. And so being a WashU, being a Barnes, I thought I'd quote Jimmy Cox. This is a paper that we don't usually get to see in the EP field. This is in the surgical literature. Have you read this one, Phil?
I have read this one.
After the advent of catheter ablation as a treatment for AFib, I performed maze procedures on approximately 35 patients in whom prior catheter ablation had failed, thereby providing direct observation of the inside of the left atrium after the attempted catheter ablation. The typical findings at the time of the operation were diffuse generalized scarring as the result of most of the endocardium of the LA as a result of previous ablation. I've never once seen a linear lesion of any type in any patient who's undergone a previous catheter ablation for AFib. Moreover, I've yet to find a single surgical colleague who has ever seen a linear lesion inside the left atrium in any patient who's undergone a catheter ablation attempt at treating AFib. So, you know, you can't get much clearer than that. You could argue, who cares if it's a straight line as long as the dots join, but still, there could still be technical issues, in which case, and this is something I mentioned earlier, maybe surgery could have the answer. So this is surgical maze, of course, developed here entirely. This is the cut and sew, and this figure is actually from your thoracic surgery paper in '92. But basically, intercable line, right atrial appendage amputated, lots of other lines. Importantly, encircling lesions around the left and right pulmonary veins with amputation of the left atrial appendage. This is not done in many centres. I think most centres couldn't do it as well as it was done here, and I think most centres have moved to using some form of radiofrequency ablation. Cryos have fallen by the wayside. So if surgery really were the answer, this is something I asked you earlier, why is it, then should surgery really fix the problem? Now I know the cut and sew results were in the 90% range. When you look at the surgical literature on using RF ablation, it's not as good. And so these are data from the Wellens group, European Journal of Cardiothoracic Surgery 08. And again, you can see, this is several years of follow-up. The follow-up wasn't rigorous, but let's just take it at face value. 1 year, 75%. So again, not bad. A lot of persistent AFib patients, but still enriched with paroxysmal. But if visualization of where you're going with the catheter and avoiding skips and just applying energy were the whole issue, I would suspect these numbers should be higher. So Rick, I was expecting
Well, you know,
a food
if
fight.
you go back to the previous slide, first of all, that's not our operation.
Okay.
There's several things wrong.
Okay.
Go to the next slide.
Yeah.
The next slide, you know, I showed you our data, the most
Sure.
recent data, and without drugs, it's in the 70 to 80% range. With drugs, it's above 90%. So, you know, I can't reconcile necessarily, I don't want to say anything bad about these guys, because I think one of the things about comparing all these studies is what the patients you have in your cohort are. And if you have patients that got 10 centimeter atria with, you know, concomitant mitral valve disease or aortic disease and, you know, 30 years of atrial fibrillation, you're going to get a lot different results than, you know, surgical series, for instance, that was done all in, you know, 4 centimeter atria with, you know, recent onset atrial fibrillation. So you know, there's this wide spectrum of patients, and it makes it difficult to compare these. I would say that, though, in all fairness, our results are much better.
Yeah.
Ralph Damiano's got much better results.
And I would agree, based on the published series, that the results here really can't be beaten. But even if the number is 82%, that still argues with extensive ablation and surgical visualization that there is probably more than a technical issue here, and that there are mechanisms that are not fully understood. And I think that's really where we. Did you have a question? Okay. So this is obviously a hard problem. And so to solve a hard problem, I thought I would enlist the help of one of the great philosophers of our age. And so I pulled off this video from YouTube.
There are known knowns. There are things we know that we know. There are known unknowns. That is to say, there are things that we now know we don't know. But there are also unknown unknowns. There are things we do not know we don't know.
So that's the Department of Defense briefing in 2002. There are known knowns, things we know we know. There are known unknowns, things we know we don't know, but there are also unknown unknowns. I thought I would structure the rest of the talk on that paradigm. So I thought let's start off. First we'll do the unknown unknowns. Okay, so so here's some known knowns, okay? So pulmonary veins are mechanistically important, particularly in paroxysmal AFib, but even then, the success rate is not 80%. I'm not going to argue that could clearly be because of technical issues. If you go and touch up reconnections, you can probably get to 90%, so let's not argue on that at all. Persistent, clearly, I think, is a complex disease with a heterogeneous set of mechanisms, and that's why I think it's important to try and understand the mechanisms using high-density mapping if possible. Essentially what Rick, John Wino, Cox did surgically back, 15, 20 years ago. And of course, it's difficult in the EP lab, but I'll show you some limited data that we have. We know many aspects from canine studies of how remodeling facilitates AFib, and two of the candidate mechanisms are refractoriness, typically shortening, but of course that's not static, it's rate dependent, which is why I'm going to talk about rate dependent repolarization, and conduction velocity slowing, which is again not static, but rate dependent. And then there are other things, and I won't go into this, although I know there's a lot of genetic expertise here. It's not my expertise. I do have a slide in this I could show later. Obviously, lone AFib does have many candidate monogenetic causes, but on the whole, it's felt that persistent AFib doesn't have a clear genetic basis. So going back to this, I've identified 3 questions which are known unknowns that we talk about. Why do premature beats initiate AFib when they're from the PVs? Why do organized rhythms organize the AFib? And could there be drivers which are sustaining atrial fibrillation? So going on to the first one of these, one of the most plausible hypotheses to explain why premature beats can initiate AFib is that there is rich innervation at the pulmonary vein regions, also in the regions marked by epicardial fat pads, also in the right atrium, which supply both sympathetic and parasympathetic efferents, which could be sites where atrial fibrillation is triggered by extra beats. This is a slide from Sherlag's work. Most of this has been pioneered in Oklahoma, and basically I'll just jump straight to the chase. This was a heart rhythm paper in 2005. They of course have had several papers since that time. The basic notion is that with appropriate stimulation, which is both cholinergic and sympathetic, or rather catecholinergic, you can see shortening of refractory periods, that can trigger early artery repolarizations, that can trigger triggered activity and something that looks like AFib in canine pulmonary veins, and that these mechanisms can be blocked by either stopping the autonomic stimulation, giving beta or muscarinic antagonists. So here's basically the paradigm. This is epicardial pulmonary vein sleeves. This is an APD from the equivalent of a monophasic action potential, and these are bipolar recordings. This is the action potential duration, and then the horizontal bars are periods of autonomic stimulation, which is basically high voltage, high frequency, which you can do in humans. And at periods of autonomic stimulation, it was noted that the action potential duration shortened, so that's one consistency with their hypothesis. They then found, as you can see, that EADs, early after depolarizations, ensued in many cases. There's probably one here, this is probably a DAD, EADs here, and caused triggered activity that looks a lot like atrial fibrillation. And then when you stopped all of this, slide once please. Okay, not working. Then basically, after the stimulation, the action potential duration normalized. And there's been a series of studies in the group that are very elegant, and I think there's no doubt that clinically there are some aspects of this that are plausible. Basically, you can clearly see cases of clinical atrial fibrillation which are autonomically mediated, either after eating or potentially when people have cold foods and so on, or adrenergic. Having said that, there hasn't really been a clear study to show that denervation of the atrium and eliminate these beats will really change outcome. There was a study by Capone in 2004 suggesting that when you denervate the atrium to a greater extent, as shown by the loss of certain reflexes, those patients do better. It's not really been supported. And there have been other studies to refute that by saying that every time we do an ablation in that region, we denervate, and yet, of course, patients can still recur. And in fact, there's even been evidence that you can renervate. So it's not clear that this is clinically important. Sonny Poe and his group, I think, are brilliant, and I think they do a superb job. They've tried to link autonomic stimulating activity to fractionation. It may be relevant, but I think at this point it's fair to say it's not clear how this relates to human AFib, although I'm sure that PACs could clearly be triggered in this way. So that leads on to the second question, which is an area where we have data. Why do organized rhythms initiate AFib? So this is taken straight from Colkins' position paper in Heart Rhythm 07, and basically you could have focal beats in one or more pulmonary veins interacting with rotors, either multi-wavelet reentry or mother rotors in the left atrium, and together these could give rise to atrial fibrillation. But if you have a rapid beat in the atrium, why would it not remain a rapid atrial tachycardia? After all, we have seen cases of typical atrial flutter, which are clearly flutter with cycle lengths of 190, and yet we've seen cases of AFib where the mean cycle length is 210 or even more. Well, it's not simply a rate thing. You could argue it's patient-specific, but why would an organized rhythm break down? And so we set out to address that, and I took this based on what I was doing here at WashU when I was a fellow many years ago, which was T-wave Alternans. And if you look at the ventricular repolarization model, you can see, and this is from David Rosenbaum's great paper in '99, basically if you paste the rabbit heart in the ventricle, and here are the QRSs, they basically look the same, up to beat 6, a bit different, but then from beat 7, you've got VF, even though the activations look the same. And if you looked at the optical mapping of depolarization, which is essentially just looking at activation isochrones color-coded, then all the beats look the same until VF ensues. You don't really understand why VF was going to happen here, but it did. If, on the other hand, you look at repolarization, you can see that while dipole looked consistent, repol was oscillating. And here you can just see very quickly that you have a different pattern which is actually oscillating in these beats. And you can see that if you look at the repolarization waveform. And so if you look at the whole waveform as opposed to what we do in EP, which is just activation, bipolar recordings completely filter repolarization information, with the possible exception of ARIs in humans, but even that's a bit tricky. So we figured that we could somehow get a handle on whether repolarization was important. So in fact, in '02 we published this paper when I worked with Michael Franz. I was privileged to do that, where we looked at patients with typical atrial flutter with spontaneous transitions to fib or paced transitions to AFib. And we found that if we put a monophasic action potential in the high right atrium and one in the low right atrium, then we can either sit around and wait for transitions, which we did for 10 minutes in every case, and then we overdrive paced. This figure shows a case, this is reverse typical flutter, just before the onset of AFib. And in fact, the high right atrium MAPs are very consistent, while the low red atrium clearly showed a 2-to-1 pattern. And this was actually a spontaneous initiation of AFib. Within 20 seconds, this actually happened, where you had degeneration, you could call it period multiplying or the onset of complex oscillations, and then AFib ensued. So we were pretty excited about this. And it tied in with what I've been doing with Alternans with Joe Smith, who used to be a faculty member here. And the question is this just the way typical flutter degenerates? Because typical flutter is a specific, limited disease, often in patients with normal hearts, not always. Slow conduction in this area where we saw the Alternans, could it be irrelevant to other forms of AFib? So I was heartened to see this paper by David Christini's group. It was a simulation study. It was a Harold Henriquez structural model with the quarter-munch ionoid model, and they showed in their simulations, they had to do a bit of tweaking to get this thing to oscillate, but they showed when you gave a couple of PACs from the pulmonary veins, and if these are sort of spun around, this is an inferior view looking at the IVC, cavernocospidismus, and this is the left, and here we're looking from the top, and this is roof, pulmonary veins, left hypertension, and right atrium is this way. But basically, no matter where you gave your PACs, you would have APD alternans prior to AFib, and they found it in their simulations to be a necessary condition. And this was, in this actual case, they initiated with 2 PACs in the left inferior pulmonary vein, that's right, and they actually got oscillations in the isthmus. In this case, they got oscillations near the PVs. But they proposed this as a general process whereby organized rhythms or PACs could give rise to AFib. And so we set out to look at this, and we published this a few years ago. In a nutshell, in every patient we saw coming for AFib ablation, I put a monophasic action potential catheter near one of the superior pulmonary veins and paced from it. So this would mean, of course, that we cardioverted persistent AFibs to sinus, which is a limitation of the study, and that people who wouldn't cardiovert were excluded, which is another limitation. Nevertheless, in the series we now have over 70 patients who do various things. I'm going to just describe a few papers on this. So these are Navix reconstructions. This is the CT, and this is a fluoroscopy showing the coronary sinus catheter, and that's the MAP catheter. It handles just like a regular ablation catheter. So it's EPT. And basically, from this, I gave either single extra-stimuli or burst pacing. I'm going to show you 2 sets of experiments. Patients had all their drugs discontinued, and I was careful to make sure AMI was discontinued. And the real question was, is restitution steep or not steep? And we'll talk about that in a few minutes. And did Alternans occur before it occurred? Okay. So I'm going to first describe the burst pacing experiments. We burst paced from the catheter, which is wherever we could get stable recording, to be honest with you. It had to be near a superior vein. It was either anterior to the left or the right. And the time domain analysis was straightforward. We would somehow find a diastolic interval, which is tricky at fast rates, but we did it. Then we identified a plateau voltage using in software with manual overread, and then the time from the plateau down to repol, so this time from here down to here is the APD 100. Because of noise at the terminus, you tend to take a point up here, APD 90, and that's what we did. You then relate this to the preceding diastolic interval, and that gives you lots of ways of looking at the rate dependence of action potentials. Another way I did this was to take work I borrowed from when I was here with Joe, and we took the action potentials, and here's an example, and we lined them up. We just aligned to the onset, and then we looked at successive beats. And this is actually, the red beats are all the evens, and the blue beats are all the odds. And if you line them up this way, you can do Fourier transforms across the beats. So basically, you've got beat 1, 2, 3, 4, 5, 6, up to 128, okay? So if you do a Fourier transform on that beat series, at this point in time, you'll end up with this kind of a spectrum, where you've got basically a DC component, and you've got noise, and then at some frequency, you may have a peak. And in this case, if the peak is half, it's every other beat, then you have oscillation by definition, it's alternating. And this is an established technique for T-wave alternans. We just applied it intracardiac, and we did this over the entire APD. So that's basically what we did. We then quantified this using some scores that we had, and the details aren't relevant. These are the patients. This was for the pacing study. So 25 patients, age about 65. Our population is older. Many of these were under VA. They're not well patients. There's just the way it is. Left atrium were pretty standard. Having said that, bigger in persistent and paroxysmal, and the rest of the parameters are shown. There wasn't anything else significant. Persistent had slightly higher heart failure. So here's an example. In paroxysmal AFib, we start pacing, and you can can see at cycle length 500, which is 120 beats a minute, you see fairly consistent APDs. I do know they're lengthening. We didn't see that consistently. Now, if you look at a faster cycle length, you can see by the numbers that there's oscillation, so there is actually alternans. You can see that the alternans is shown here by long, short, long, short, long, short. And if you look very closely, this peak at the end of phase 2, phase 3 is a bit taller than this peak, which is a bit smaller than this peak. And this became more marked at cycle 250, where you can see that in fact this peak at phase 2, phase 3 is lost every other beat. And then we were talking about discordant alternans earlier. So there actually is discordance here. You could say discordance or more complex oscillations just before the initiation of AFib. Pacing-induced AFib does have criticisms associated with it. We'll come on to that. But basically, we got AFib in essentially almost every case of paroxysmal AFib in this way. We then plotted the action potential duration against diastolic interval, and the slope was steep. We'll come on to that. Here's a case of persistent, where we basically have the same thing. Nothing at 500. You start to get oscillations at 320, and then at 280 in this case, again we got very clear oscillations, which then became very complex, giving rise to atrial fibrillation, and the slope was steep. So although pacing-induced AFib can be criticized, we actually saw this in a few patients with relatively slow pacing, almost spontaneous AFib. So this is pacing at only 450, which is about 130 beats a minute, and basically a PAC happened just here, and then AFib initiated. So on the setting of alternans relatively low pacing rates, we had a PAC that initiated somewhere here, more centrally than this, and gave rise to AFib. So we do have evidence that this is part of the spontaneous pattern. The summary really was that alternans started at very low amplitude at slow rates, increased in amplitude at faster rates towards the initiation of AFib in every patient. Interestingly, there was a difference between the patients with persistent and paroxysmal, and I'm going to come on to that in the next piece of work. But basically, you can see that in patients with paroxysmal atrial fibrillation, there was a big jump in alternans at every rate increase until you got AFib, whereas in persistent, there was a higher amplitude of alternans at the initiation, even at slow rates, and then the increase was actually not that significant at faster rates. And I think that in persistent AFib, oscillations and repolarization are one, but probably not the primary mechanism. So, are there any questions on that portion? Okay. So that's the first demonstration of alternans being present before every episode of atrial fibrillation. There's data that we'll show if we have time at the end, but in patients in whom rapid pacing gave rise to 2-to-1 block and didn't cause AFib, there was no alternans preceding that. So what could be causing alternans? This is not news to many of you here, but the rate dependence of action potential is one of the major contributors. There are actually two things I think about. That is, one is a steep restitution curve, and the other is dynamic conduction slowing. So very quickly, should I go through this quickly, or should I spend time on this?
It's fine. Just
okay.
You can
So the rate dependence of action potential duration with heart rate or the space between beats can be described here by the action potential duration restitution curve. Basically, if you think of this as slow, I'm going to go back in that case. You think of this as slow rates, and this is fast rates. At slow rates, APD is long. As you start to get faster rates, APD gets shorter. So it's a bit like QT shortening when you get faster. Now, the slope here is critical because this slope indicates what happens when you get a very early beat or very rapid changes in rate. And if you start off from this baseline interval, and from this baseline point A, if this is a premature beat, then if the slope of this relationship is less than 1, then the change in the APD is less than the change in the diastolic interval. In other words, for any given change in DI, you get a smaller change in APD, so that this will basically converge and the oscillations will dampen. If on the other hand, if you have the restitution slope greater than 1, the opposite will happen. Every change in diastolic interval, because the beat is early, will then be followed by a bigger change in action potential duration, which will then give a smaller change in diastolic interval, that will give a very much smaller APD, that will then give a much longer diastolic interval and a much larger APD, and so on. The whole thing will actually amplify to the point where APD blocks, and you can get the initiation of wave break. And so this is basically the notion that steep restitution could predict wave break in atrial fibrillation. This has actually been shown in numerical simulations, but never in AFib until this. So in the paroxysmal patients, here we have end of a drivetrain, so S1, 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 S2, and we just measured basically this APD against this diastolic interval, and then we did it for the next S2, and all S2s down to refractoriness, and we plotted them, and lo and behold, the slope at the maximum portion is greater than 1. And we actually saw this in almost every patient with paroxysmal AFib. So you can say, okay, that sounds all right, that's consistent with this restitution idea that it would be nice if early beats gave rise to steep restitution. But if that's true, then really, when you give an early beat, you should spiral out, you should spiral and amplify and get AFib. So unfortunately, we didn't get this in all patients, but in fact, 5 patients did have AFib initiation from a PAC, and here's one of them. S1, 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 S2, which is a short APD, and then we had AFib initiate. So I plotted the restitution curve for this, and here it is, and here are the beats. This is the last pace beat. This is the premature. You can see that there's this oscillation. Back to the first fibrillatory beat, forward to the next fibrillatory beat, you can see the oscillation. So this example actually does follow that, and all those 5 examples did. Why the other 22 or 27 didn't is, we'll come on to some of that later. It could have been autonomics, it could have been sedation.
So did it depend on where you paced from? Did you move your pacing electrode around?
It's difficult to do these studies technically. We have 5 patients that we paced from the lower right atrium on the endocardial side of the coronary sinus. One of them, 2 of the 5 had steep restitution, and in one of those AFib was induced. There definitely is a regionality to this, and actually that's something I'm showing that. We looked at that in Bordeaux as well, because Michelle.
It depends on where you pace from. The other question is, do you know what's the restitution slope in a normal atrium that doesn't fibrillate?
Yes. We have 5 patients who consented to have this protocol, and it was less than 1 in all 5. Right? We'll add that slide. I should have known that you'd ask me that question. Yeah. So it's less than 1. Now, does that prove that APD are greater than 1? No, it doesn't prove that it's instrumental, but it certainly shows a consistency. And there are other data we can show as well. The regionality is important. I chose the PV specifically because we have to choose. If you have to choose one area, you want to choose the place where most of the atrial triggers are. That's why we picked it.
Can I ask a technical question?
Please.
How did you determine your slope here? It's obviously you fitted it through some points, but how did you determine where you fitted it?
We took the shortest DI, which in this case is probably -4, and we went up to a DI of 40.
Okay, so you had a fixed interval, and you always use that.
So we used a DI range of 40 all the way across, and if you look at the paper, we actually have the 3. So I took a few off for clarity, but there's one like this. Sorry, there's one like this, one like that, one like this, and then they go like this, and we just took the steepest of those. And the reason I did that was I didn't want to fit a semi-log curve, because if you fit a semi-log curve, you always overestimate restitution slope. Because down here, this restitution, the slope here is going to be about 10.
Right, yeah.
And so I didn't want to do that. So Michael Francis said, he said it's better to actually do it this way. So we used we fitted this just because it looks good. The dotted line looks good, but we actually use the real data for the curves. So it's important to cast a wide net. Okay, the Mars rover could have seen this. In fact, this is what they sent back. But what it should have looked at was with a wide-angle lens is this. So when you look at the restitution slopes, we actually looked at this and found that the paroxysmals were steep, the persistents weren't. And it didn't make any sense initially. Here's a persistent AFib case. None of them had a restitution slope greater than 1, even though they're in AFib all the time, almost by definition. And here's an example: S1, 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 S2, and here are the APDs, abbreviated because we know that remodeling APDs are shorter. And you could argue with the APD quality. There are several in the paper. I picked this to make another point. Here's the slope, which is less than 1. Now, here's something I actually showed Rick, and this is what I'm having a hard time explaining this. First of all, of 13 persistents, none had a slope greater than 1. The maximum was actually this patient. And one of the reasons we're almost certain of is that this actually reflected this tremendous activation time delay. So if you look at this, if you go back, if you look at the S2 beat, there's an activation time delay of 100 milliseconds before that pulse, which we know was delivered, and this onset of phase 0, which is a little slurred. And we know that this is a real activation because there's the coronary sinus atrial electrogram. Whereas if you go back to the paroxysmals, it wasn't like that. If you go back, it basically was almost immediate in the, if you look at this one, see, there's almost no activation time delay. I think the activation time delay in those was measured in about 20. So we actually found this in almost all the persistence. And so this project became really a conduction dynamics project, and that's what we're working on now. One interpretation is because you get dynamic slowing, your early PAC near the pulmonary veins in persistence encounters so much dynamic delay that by the time the next beat, the rest of the atrium sees it, it's late. It's not early anymore. And so the restitution curve is truncated to the left. We don't have any points below 25, which is where you'd expect it to become steep. And so that's one interpretation. The other interpretation is that in fact, the membrane currents responsible for terminal repolarization have altered so that you don't see the same rate dependence. And we're modeling that actually with Natalia, that's a paper that we're working on currently.
I'm sorry, going back to that.
Yes.
Is this after you cardioverted that you're giving the S1, S2?
Yes, unfortunately that's a limitation. Everybody was, all the patients were in sinus by definition. You can't pace if they're in AFib.
Okay.
However, 2 of the patients, or 3, I have to look at the paper, presented in sinus rhythm at that time for AFib before, even though they had persistent history. And so we were able to do this and get AFib. Okay, so although you can argue cardioversion.
And the APDs were longer and persistent, I think.
Shorter.
Didn't you show a table before that showed that the persistence had longer APDs?
Shorter.
But they were shorter.
The restitution curve slopes were steeper in paroxysmal and persistent. The APDs were shorter in persistent and paroxysmal. So we plotted conduction, and basically saw this in paroxysmal. If you start giving S2s at progressively earlier coupling intervals, then the activation time, which is a surrogate for conduction perhaps, doesn't really change until a certain point when it starts to prolong. This, Jim Weiss would call this preserved restitution. And then here, where you've got a case of persistent AFib, you've now got early beats coming in without any change in activation time, and then at a relatively long diastolic interval, 100 as opposed to only 25 here or 30, you start to get slowing. And so what this means is this is relative activation time normalized to this. And so you can see that any beat that comes in with diastolic intervals of 100 milliseconds or less will experience some slowing. And of course in AFib, you will probably have almost all of your beats in this range. And so the dynamic slowing could be important. And I am increasingly beginning to believe that it's not just the baseline conduction velocity, it's the dynamic change. And here, so if you look at paroxysmal persistent, a lot of studies have looked at conduction velocity as in patients with AFib using activation times as a surrogate. But they've almost always just looked at 1 or 2 basic cycles. Like Kalman's group had a paper by Roberts, Thompson, and Jack in 08, and this is what they did, baseline. And there's actually no difference at baseline. But when you look dynamically, you can see a tremendous difference in dynamic slowing in persistent versus paroxysmal. Very little in paroxysmal versus more in persistent. Even.
So I was wondering if there was any data about anisotropy. We found in ventricular, in dilated cardiomyopathy in human hearts, at fast rate you get not just slower conduction velocity, but also isotropic ratio actually changes dramatically from, let's say, 3.5 to 7.2 at fast rate. And of course then it leads to transverse block conduction. Are there any studies in the atrial tissue?
You probably know this, the data on human fibers is really scanty. We're actually looking at this now for modeling, and there's a study by Papez in the 50s, and there were some studies from the 1920s, and it has not been studied systematically. Of course, DT-MRI is not going to be as effective in atria, we hypothesize that the fibrin was less conserved than the orange ventricle. We're trying to address the myth, but I think that's a superb question. I mean, it has been proposed, and it's known from dog studies, that there's tremendous fiber complexity around the osteoid veins. There's a crisscrossing in the posterior left atrial wall. That's been shown. And then studies using the ASI mapping system have shown that if you pace very rapidly, you can get areas of functional block. The septopapillary bundle of Papez, which is just off the septum of the left atrium. So we're not sure. See, that doesn't have to be fibrin isotropy, but I think that's an important thing. We're actually exploring that now. It's a great question. So the biggest difference here, as you can see, is that the dynamic conduction delay between the two patient groups is different. And in a nutshell, this is the current, we're moving forward, we have more data, but it's not quite ready to show. APD oscillate greater than 1 may explain how PACs initiate PAF, and let's call these normal hearts, in other words, without a lot of remodeling. When you have a more remodeling, potentially more fibrosis, then dynamic conduction delay could be more important, and potentially that could make APDR less important. And again, this is speculation, but this could explain potentially why PV isolation, which we think of partly, not entirely, as a way of eliminating PV triggers, may be less important than persistently fit, because it's not trigger related, because the triggers don't actually work in the same way. That would imply, of course, that persistently fit has to have rapid repetitive activations, which hasn't been shown yet. Maybe you can show that with the ECGI stuff. So I think that's interesting. Final 5 to 10 minutes. So what about this paradigm? Could this apply to AFib? You've got a centralized area of relative organization that drives the chaos. You have a driver for atrial fibrillation. And I think this has been shown beautifully by many groups, including, of course, Halife's work in sheep optically mapped atria. And this is an example from Skanes 98, where this represents a couple of centimeters squared of optically mapped sheep tissue, rapidly paced, of course, excised, and you can see that a rotor indicated as a red to blue or a head meets tail activation pattern is shown in some of their animals in this paper. Rotors were meandering and actually not stable in space. In a few, they were stable in space, and I've seen it present on both. And that, of course, would be an important factor, because if we're thinking of this as a surrogate for human AFib, if these things are moving, it's the same in a way as migratory re-entry wavelengths. If they're fixed, that's hugely important. Of course, how do we measure this in humans? You can't optically map, it's hard. You could do it in the OR, you could do it with ECGI potentially, but otherwise it's tricky. So surrogates have been developed, such as here. This area, I think it's region 1, with regions 2 and 3 surrounding it. And if you now look at the electrograms in region 1, they're organized with a narrow and rapid spectral dominant frequency. As you look at the electrograms in region 2, less organized, a slower and slightly broader spectral pattern. And in region 3, less organized still and more of a broadband spectrum. So that's the idea that if you potentially look at high dominant frequency, you're looking at that central driving element. That's been the hypothesis. And so you see the step down in rates and regularity. First study I'm aware of that looked at this in humans was Sahadevan from Al Warder's group. And so in 9 patients in the OR, high density recording parts in various regions of the atrium. And they did, this is one example, they did show rapid activity here, so high dominant frequencies, very organized electrograms, pretty impressive really. These were persistent AFib patients, not undergoing maze. And then elsewhere in the atrium you saw less organization and a broader dominant frequency.
What is your definition of dominant frequency?
Thank you for stopping me there. So the notion is that if you do a simple Fourier transform on that voltage time series, that you look at rates which are plausible, and people typically look at rates between about, in humans, they look at about 3 to 4 hertz up to about 15 to 20 hertz, and they pick the tallest peak in the Fourier transform in that bandwidth. 3 to 4 hertz would translate to a cycle of 300 milliseconds, which is about the slowest you could ever conceive of for AFib. It's probably too slow. And 20 hertz would be a cycle length of 50 milliseconds. So let's say 15 hertz would be 75. That would be about the fastest. So you pick the tallest. It is a problem, and I think that's why the clinical data is less clean. But you basically pick the tallest one. Theoretically, it should also be the narrowest one. But does that answer your question?
It doesn't. It's just very messy.
it is messy, and actually that's a great point, because although this looked quite good here, you can imagine it's really, it's even in this one, you could, of course, we've all seen the papers, people pick this peak, but you know, I know that if you just move the window around, you could actually you could have a huge difference in the spectral dominant frequency for the same cycles. I haven't got the slide because I didn't think I'd be asked this, but basically, the Northwestern group did the following experiment. They took human AFib electrograms and they did a dominant frequency on it. Then they took exactly the same electrograms, the same intervals, and shuffled them, and they got a totally different dominant frequency. So the sequence really matters. And they shuffled them again, and every dominant frequency was different, and the range was between 5 and 7 hertz for the same cycle lengths. And then, if you go and change the magnitude of the shape, it changes again. So there are issues with applying this clinically. And this could be why in the biggest clinical study of this, which was Sanjiv et al. From Hasega's group, if you look at paroxysmal AFib, each dot is a patient, and it indicates the highest dominant frequency location in that patient. This is the atrium viewed from behind, right atrium, left veins, right veins. Then it's folded back over, so this is the mitral annulus tricuspid, this is the ASBC. So there were lots of dots near the pulmonary veins. So that's pretty good. I mean, that's a plausible area where you could expect to have high dominant frequency. And indeed, AFib terminated and was successfully cured when you ablated there. But even in the paroxysmals, loads of these dots were areas where they'd never ablated. Okay, you'd never ablate, you wouldn't really ablate here at lateral tricuspid valve. And so even in paroxysmal, it didn't really work that well. And in persistence or permanence, it didn't work at all well. So although I know that Khalifa's group and Jerome Khalifa are working on this heavily, there are some issues. We can talk about why. I think there are technical problems with this. We had a paper, we're looking at a slightly different approach. We used the basket, constellation 64-pole basket in the left atrium. We're continuing this work for different reasons. And we just said, okay, if it's a driver, you should have a step down in rate and regularity between the central point and peripheral point. So we did a brute force search algorithm looking for dominant frequency and dominant frequency width at every electrogram compared to all its nearest neighbors and the next neighbors. And we found that in fact, it was a small study, 20 odd patients, 25. And in 3 patients, we actually were able to show that that point was where we were able to terminate acutely. One was LA appendage, one was near the LSPV. So I think that's another way to do this, because that incorporates the spatial information that you don't have just with a single catheter. I still think there are problems. I mean, if you look at this, that's the dominant frequency, but there are lots of other candidate peaks. And here, I think you need to answer your question. I mean, this is a tricky one. And there's a lot of arbitrariness to that. So what does wave mapping tell us about 2 minutes? Or will that be okay?
It's fine.
So we're getting on to the final topic, and that's what's fractionation, because this is interesting, I think, to the clinical EPs here in the audience. And of course, this was the seminal paper that got this started. This was unipolar electrograms in the epicardium of the right atrium surgically. But unfortunately, these were patients without AFib. They were Wolff patients, Wolff Parkinson-White patients with an accessory pathway who were induced into AFib. And therefore, it's not clear that whatever is seen here was actually important for sustaining clinical AFib, because these patients didn't have that. Nevertheless, several patterns were found using the mapping plug, and it was found that at sites of collision, you could have complex electrograms with multiple peaks, whereas at the regions of relatively laminar conduction, you wouldn't. Similarly, regions of block, along the block line, more complicated potentials, even a double potential here. At pivot points where you could have migratory rotors or small reentrant waves, fractionation, slow conduction fractionation again. And so this work has been used without the benefits of all the mapping points by EPs to say, okay, how about if I just use my one catheter probe, because that's typically what we have, and we move it about. When we see this, we assume it's one of these slow conduction or pivot points and burn it. And in a paper published in 2004, that was shown to have success as an alternative approach. Naryan did not target the pulmonary veins. He just went looking for these fractionated electrograms and he burned them. And that caused a lot of excitement. Since that time, there have been several studies that have not been as promising, these are 2 of them. But nevertheless, people are still interested, because I think there probably is something to this. But there are probably many different forms of café, as it's known, which dilute the success of this. for every one that's a pivot point, you could have 5 which are collision, and if you've got waves crashing, ablating them may not be particularly relevant. So this is a paper to show slow conduction. So this is one of the projects I went to do when I had the privilege of working with Michelle Hassegain last year on sabbatical. This is Melissa Orsini. And so I got a grant to use a map catheter that's not available in the States. It's made by Biosense. And I wanted to do high-resolution local mapping using pentaray catheters or spirals at regions of cathing to see if we could identify something that made sense. Are these pivot points? Are they wave collision points? Are they potentially artifact? What are they? So in this particular case, this is across the interictal septum near the atria of the left superior pulmonary vein. These splines are a bit scrunched, but I think you'd agree that D, so this would be D here, DC a bunch, but that would be D 13, 14, 15, 16. So the map is pretty close. And we did get 2 views, and they are in plane, so this is not opposite to that. So the red is shown, it's very fractionated. What would you expect, Mitch, the action potentials to look like in that region?
No.
So very short. I expected to see that. Very short action potentials, very complex activity, a lot of far fields, and this is what we saw. So we actually found at this position that there's a tremendous regularity. There is variation, but more regularity than we would think. Incredibly slow local activation compared to what I would have expected to see. Okay, I would have expected these cycles to be down in 100 milliseconds, 70 milliseconds. Not true. Now, the problem with the map, of course, is it's a broad area integration, at least a centimeter squared. And so, and I think I asked somebody earlier, I asked you, Leonid, what would you expect to see if there was discordance or heterogeneity within the spatial mapping field? You might actually see this kind of variation in the map. Of course, this could also be the catheter was moving. I don't believe it was. It wasn't. I don't think. But anyway, it's possible. It's possible. So we saw this. Here's an interesting one, where this was in the endocardial side, inferior left atrium, endocardial side of the CS, and basically you can see that the MAPs are clearly showing different morphologies despite a huge attempt to get good contact. And I do think the contact was stable. If you look at the catheter here, you've basically got a spiral, which is available here actually. You can get this by Sanjiv. And the electrodes are labeled 1, 2, 3, 4 as you move in. And the inner portion here is 20. And here they are spiral 1 to 20. Because of the way they are, of course, there's overlap. So 1 to here, which is 13, is all you really need to see. The rest of them are duplicative. And so if you look at 1 to 14, you actually can see that activation follows a pattern that does vary a little, but basically does show, at least for several of these beats, a sequential activation pattern which spans the entire cycle length. For what it's worth, the dominant frequency was narrow at that point. And so we do think that actually it will be possible to use this approach to identify where you have discrete activations. I do accept the variation is a problem. That this might be a way of identifying pivot point fractionation sites as opposed to others. We have a lot of recordings actually. This is a case in the RA appendage where we all know that fractionation can occur when the AFib accelerates, then it can go away when we slow down. And so here we have tremendous changes with fractionations periodic. And if you look at the cycle length, it is actually rate related. You've still got pretty discrete MAPs, and we have I won't bore you with all the details, but we have other patterns that we saw, including some that were clearly artifact. Maybe I'll show you Jane and Mitch later. But basically, we think that this is a way we can move forwards and try and identify more mechanistically important cafe spots. The proof of the pudding, of course, would be to ablate there. I did the analysis after the cases, and so it was retro. So we're doing this prospectively now in San Diego. And, so I think we're basically done. Just to say that this is for Mitch actually. So after one of these cases, we would have a hard morning. So the traditional lunch would start off in this way. This is a phenomenal. This was wine tasting at Chateau Issin in Margaux, and this was versicles of Chateau Issin, going back to a 1927 port. I know that Europe's been treated to this level of hospitality also. So anyway, in summary, human AFib is highly prevalent, yet still poorly understood. in patients with minimal atrial disease, paroxysmal AFib, we believe that steep APD restitution may explain AFib initiation from a single beat. When more structural